Welcome back, friends. In part 1, we met our 68-year-old patient who felt like he had aged 10 years in 3 days with profound fatigue, dizziness on exertion, and needing help just to get from the lobby to the exam room. Vitals revealed the showstopper, a heart rate of 27 beats per minute. EKG confirmed sinus bradycardia. Today, we'll walk through a high-yield 4-step approach to bradycardia and reveal the cause in our patient. Step number 1 is recognizing the problem. You first have to ask the question, are the patient's symptoms due to bradycardia? Here the answer is easy because the heart rate is so low, but many times in the hospital, you'll get a call from a nurse that a patient's heart rate is 40 while they're sleeping. The key difference, the patient who's sleeping is asymptomatic and their heart rate is appropriately low in the context of increased vagal tone during sleep. Once you see a heart rate in the 20s, the chief problem isn't fatigue or lightheadedness anymore. It's symptomatic bradycardia. That instantly activates 2 mental tracks. Management reasoning, do I need to give atropine? Get pads on the patient, have IV access ready. And 2, diagnostic reasoning, what's causing the bradycardia? In step 2, once you identified it as symptomatic bradycardia, now you got to classify the bradycardia. But in order to do that, you need to know the normal electrical pathway of the heart. So the electricity starts in the SA node, it goes down to the AV node where there's a pause, then down the bundle of His to the right bundle with the left bundle simultaneously, and then a bunch of Purkinje fibers, depolarizing both ventricles and getting this beautiful coordinated contraction of the ventricles. So now that you know the normal electrical activity of the heart, the first branch point is what type of bradycardia are we dealing with? Sinus bradycardia, issues of the SA node, or non-sinus bradycardia due to AV nodal disease like second-degree heart block or complete heart block. Or 3, pathology that's affecting both the SA node and AV node and the heart globally. Only a 12-lead EKG and rhythm strip can tell you. You got to be able to march out the P waves, march out those QRS complexes, and make sure that they are coordinated. In our patient, when we did this, we got sinus bradycardia, but let's go to my favorite EKG website, Life in the Fast Lane, to use one of their examples because it's so important to be able to recognize this pattern. All right, here we are, Life in the Fast Lane, and this patient's EKG is showing a heart rate of about 35 beats per minute. We don't have a rhythm strip here, but what you will do is go to one of the leads where you can clearly see the P waves. I can see a P wave right here, then a QRS and a T wave. So I would take a piece of paper and I would mark down the first interval of the P waves from P wave to P wave. And then if you do that, you'll see that they march out perfect together. But that still doesn't mean you have sinus bradycardia, because when you have complete heart block and dissociation between the atria and the ventricle, the P waves will march out regularly. But we have to do the same thing with the QRS complexes. And if you do that, you'll see regular intervals. But this is key. Then you want to make sure there's a good relationship. That is, the P wave is coming before the QRS each time. And you can clearly see that here. So now we can say that this patient has sinus bradycardia. The most important step for a clinician to solve a problem accurately is framing the right problem. Now we've refined our patient's problem to 3 words: symptomatic, sinus, bradycardia. So in step 3, you need a schema to approach sinus bradycardia. And here's a memorable mnemonic that will capture the majority of causes. V-LIDO, think lidocaine, V-LIDO. V stands for vagal tone that is pathologic. Lytes, specifically hyperkalemia, hypermagnesemia, hypercalcemia. I for coronary ischemia. D for drugs like beta blocker, calcium channel blockers, digoxin, and O for low oxygen. The first pass in any hospitalized patient includes checking meds, electrolytes, and signs of coronary ischemia. He was on stable carvedilol doses with no signs of overdose. His electrolytes were normal, and there was no symptoms of coronary ischemia. After you've ruled out the common triad of meds, Lytes, and ischemia, we must expand our search. And before you move on to less common causes of bradycardia that we'll touch momentarily, don't forget the V, pathologic vagal tone. That is increased parasympathetic activity and slowing of the SA node. This is classically transient. Think vasovagal syncope when someone sees blood, or carotid sinus hypersensitivity when someone is shaving. But if vagal tone was the culprit in our patient, then it must have been from a persistent cause. And one odd but real cause that we learned through this case, urinary retention. For reasons we don't fully understand, bladder distension can trigger vagal stimulation and slow the heart rate dramatically. Just like increased intracranial pressure in Cushing's can slow the heart rate through increased parasympathetic activity, or abdominal insufflation during surgery can lead to increased vagal tone. A savvy ER nurse noted his mild AKI and got a bladder scan. It showed a liter of fluid. A Foley was placed, about a liter was drained, and his heart rate normalized immediately. So let's update our problem. Fatigue from symptomatic bradycardia. Symptomatic bradycardia from increased vagal tone. Increased vagal tone from urinary retention. But we're not done yet. Why increase urinary retention? We don't have time in this episode to share our approach to urinary retention, but in his case, it was a common cause. That is enlargement of the prostate. So final diagnosis, BPH causing urinary retention leading to vagally mediated bradycardia. The key takeaway can be summarized through our figure for bradycardia, which we'll review now. So here I'm going to our website, rlrcpsolvers.com, typing in bradycardia. And here we have a schema on bradycardia. And by the way, this website is behind a subscription, but here's our 4-step approach. This is a little different than what we discussed. Step 1, if the patient is really bradycardic, ask the question, do they have severe symptoms like hypotension or heart failure? Because then you'll go down the ACLS algorithm, atropine plus minus dopamine plus minus pacing. In step 2, you really want to ask the question, is it sinus? March out those P waves, march out the QRS, look at their relationship to one another, or is it non-sinus? Because if it's non-sinus, it's always pathologic. But if it's sinus, it could be physiologic, someone sleeping, or they're an athlete and they become so efficient at pumping blood that they don't need a high heart rate. Or is it non-physiologic? And oftentimes, if the patient is symptomatic, that's your sign that it's non-physiologic, like our patient who had fatigue and lightheadedness. So in step 3, you can start thinking about the DDX, and we already shared the first pass is V-LIDO. In the second pass with the TSH, infections, infiltrative disorders, let's say Lyme disease, sarcoidosis, these are more likely to cause AV nodal disease than to cause sinus nodal disease, therefore less likely to present with sinus bradycardia, though hypothyroidism certainly can present with sinus bradycardia. And then in step 4, looking for reversible causes. If you found this breakdown helpful, we'd love for you to subscribe so you can join us for more cases like this and share with anyone you think might find this useful. And remember this, study a little bit today so you're smarter tomorrow than you were yesterday. We'll see you next time.
That's a wrap, folks.